Hello everyone, I am Dr. Masood Khan. Today our history presentation includes the CA lung. My patient, Mr. Mohammed Shabir, 60 years of age, married, having 3 children, labor by profession, resident of Karachi, presented in the pulmonology OPD 15 days back with chief complaint worsening of cough 2 months. My patient is a non-diabetic, non-hypertensive, no case of smoking for last 40 years with past history of cough for last 5 years. Presented in pulmonology OPD with worsening of cough for last 2 months. Cough was gradual in onset, progressively increasing, initially mild to moderate in intensity and is productive, containing 1 to 2 teaspoon sputum. The sputum is thick in character and it is non-foul smelling. There is no diurnal association or seasonal variation of the cough, and cough is not aggravated by exercise, cold. Previously being relieved with inhaler, and the cough symptoms now does not respond to inhalers for the last 2 months. For last 15 days, there is a blood in the sputum, 1 to 2 teaspoon with each episode, and there is no clot in the sputum. However, he denied bleeding from any other orifice of the body, any purpura, any petechiae or bluish discoloration of skin, and any use of blood thinning agents or painkillers. The cough is associated with unintentional weight loss, 8 to 10 kgs in the last 2 months, with decreased appetite. There is also complaint of left-sided chest pain, which is gradual, dull, mild to moderate, score 4 by 10, non-radiating, more with deep inspiration and coughing, with no tenderness and relieved by taking painkillers. It is also associated with shortness of breath on exertion, progressively increasing for the last 5 days. Initially, it was increased on climbing stairs, but now he gets breathless with 100-meter walk, and now not relieved with inhalers in spite good inhaler technique. There is no history of night sweats, lumps and bumps in body, hoarseness of voice or difficulty in swallowing. There is no past history of tuberculosis or family history of tuberculosis, and there is no history of foul smelling, copious amount of sputum which increases on postural drainage. There is no exposure to pets, birds, dust, factory fumes, personal atopy or any whistling sounds in breathing. No history of IV drug abuse, high sexual behavior or poor dental hygiene. No history of high-grade fever with rigors and chills and nasal congestion. No history of nasal discharge, post-nasal drip, blood in urine or numbness in hands or feet. There is no history of oral ulcer, joint pain or hair loss. No history of any recent cardiac event. No shortness of breath on lying flat or shortness of breath causing awakening from sleep. No history of any pink frothy sputum, and no history of valvular heart disease. No history of any use of antihypertensive drug like ACE inhibitors or beta blocker. No history of any epigastric pain or dyspepsia. Patient has history of smoking for last 40 years, 25 peak years, continue smoker he was, and he was aware of side effect of smoking but never tried to quit it. Patient denied any exposure to radiation, metals, cold, fumes, alcohol, or biomass fuel. There is no family history of any malignancy, no previous history of any pain in the legs or red leg lesion. There is no history of neck vessel engorgement, facial swelling, early morning headache, hoarseness of voice, dysphagia, stridor, and palpitation. There is no history of loss of sweating or drooping of eyelid, shoulder pain, or unilateral muscle weakness of the hand. There is no history of headache, fits, or altered sensorium, postural dizziness, or any focal deficit. No history of yellowing of sclera or right hypochondrial pain. Patient gives history of fluid in the lungs. He gives history of fatigue and repeated chest infections for which he did multiple emergency admissions. With antibiotic use, it was recovered. There is a history of on and off constipation, bone pain, and polyuria. There is no history of moon phase or easy fatigability and bruisability, muscle weakness, flushing of the face, chronic diarrhea, tender breast, peripheral neuropathy, frothy urine, hematuria, heat or cold intolerance, or any unilateral leg swelling. No history of any ICU admission or for mask ventilation or mechanical ventilation. According to the patient, up till now he has done multiple investigations, sputum test, fluid aspiration from the middle of his lung. Imaging include chest X-ray and CT scan chest, pulmonary function test, but he is unaware about the result of these tests. According to him, further test is going to be performed. Patient was already on inhalers. Now during this hospital admission, he has been given nebulization and oxygen as well. There is no history of palpitation, tremor, or oral thrush. He denied being given any chemotherapy up till now. Patient history dates back 5 years back when he had a cough with shortness of breath and was started having some regular use of inhalers, and advice of cessation of smoking was given. This was the past history. He had multiple hospital admissions for cough and shortness of breath. His last admission, including 10 days duration, was 1 year back with fever and shortness of breath, and he was managed on acute basis. And he also developed COVID-19 pneumonia, and he was kept on oxygen therapy, nebulization, plus IV antibiotics. Later, patient was discharged after negative PCR test of COVID-19. Inhalers and steroid he was put on, but he was not advised any LTOT, long-term oxygen therapy. He was advised follow-up after 2 weeks that he didn't perform. His past surgical history include left inguinal hernia repair at the age of 42. There is no history of any allergy, and no alcohol or IV drug abuse or high sexual risk behavior. Family history, that is a 40-year manual labor with 3 kids and 2 daughters, 1 son, all married. His son is having hypertension and on medication. There is no history of smoking and malignancy in family. He has got 1 dose of COVID vaccine one and a half year back. There is no history of influenza or pneumococcal vaccination. There is a history of BCG and mark is seen on the right side of arm. There is no significant travel and transfusion history. Socioeconomic history includes his labor by profession throughout his life. However, the job impact of this shortness of breath has reduced his activity and he has difficulties in reaching the means of his family. Functional status: patient is unable to go out of home or move uphill or climbing stairs, but he is able to do his self-care activities. So differential diagnosis on the basis of history. CA lung is the first differential, pulmonary tuberculosis, and number 3 is chronic obstructive airway disease, the exacerbation of chronic obstructive airway disease. On examination, an old cachectic male with IV line in the right cubital fossa remain well cooperative during examination, sitting on bed with vitals blood pressure 110 by 80 mm of mercury with no postural drop, pulse is 98 per minute regular and bounding pulse is noticed. Respiratory rate is 20 per minute. Patient is afebrile with a positive finding of anemia and temporal wasting, clubbing, nicotine staining, and right hand supraclavicular lymph node 2 cm enlarged, non-matted and non-tender, and fixed to underlying skin with no discharging sinus. There is no history of jaundice, pulmonary edema, JVP rise, gynecomastia, abdominal stria, spinal tenderness or sternal tenderness. The respiratory system on examination shows no scar mark, deformity, visible pulsation or prominent veins on inspection. The respiratory rate is 20 per minute. There is a puncture mark on the left base. Trachea is central in position with reduced cricosternal distance and decreased chest movements on the left side of chest. Chest expansion is 2 cm on lower chest. Decreased vocal frematus on left infrascapular area. Percussion note is dull in left infrascapular area. Vocal resonance is also reduced in left lower chest. Other systemic examination is not significant. Cardiovascular system includes the normal S1 and S2 in respective areas with no added sound. And the apex beat is in the left fifth intercostal space. There is no left parasternal eve, and however there is loud P2 in the pulmonary area auscultation. Abdomen, there is no ascites and no hepatomegaly and splenomegaly. The musculoskeletal examination is normal, that is normal tone, The bulk is normal in both upper limb and lower limb. However, the cranial nerve in left side, it shows ptosis, and there is mild cerebellar signs, and sensory system is intact, while the left eye shows ptosis, meiosis, and anhidrosis over the face, upper face. Now, our patient, why not? It is bronchiectasis. There is no postural drainage in the past and no copious amount of sputum. No history of pulmonary tuberculosis. No hematuria or blood in the urine. Smoking always cause lung CA, though it is active or passive smoking. We have to ask about the inhaler name. If it is blue inhaler he uses, that is the salbutamol, or the red one, that is inhaled corticosteroid. And we have to check the technique of inhaler. He has quite good technique. So the CA lung first risk factor is smoking in this patient. That's why we are looking, and now we have to ask some certain specific questions regarding smoking. That how many pack years he has, and does he notice any side effects? He wants to quit the smoking. Has he ever tried to quit the smoking? Has he has any other history of smoking associated with alcohol or other addictions, other illicit drugs, any family history of malignancy, any prolonged occupation like exposure to dust or metal exposure, industrial exposure, that lead to the rise of CLM, that it increases the risk of CLM. So patient is for last 20 years and a smoker, and 20 pack years he is aware about the smoking is a bad habit, but didn't attempt it to quit or decrease its frequency. So an active smoker with no any other risk factors presented with shortness of breath, hemoptysis, and chest pain, chest tenderness on the left side with meiosis, anhidrosis, and now the complications of CLM includes paraneoplastic syndromes, in which Lambert-Eaton syndrome stands first. That is the muscular weakness that improves with movement and is associated with dry mouth and palpitation. Increased parathyroid hormone that presents as hypercalcemia symptoms like polyuria, constipation, and bone pain. Cushing syndrome, that is due to SIADH, there is increased weight gain, moon-like face, hair growth on the face or body, and the patient gets diabetic and hypertensive, and abdominal stria that are mostly horizontal in Cushing syndrome, and pink stria. SIADH symptomatically it presents as hyponatremia, tiredness all the time, and fatigability all the time, as well as altered state of consciousness and fits that may point out to metastasis or SIADH itself. Ptosis, drooping of eyelids, double vision, that includes Horner syndrome. Heart may cause or may present as infective endocarditis in lung cancer, that is known as merantic endocarditis, along with pulmonary artery hypertension called pulmonary. So we have to rule out these findings in the chest. Abdomen includes ascites, distended abdomen, hepatomegaly, bulging on the right side of upper abdomen. While upper limb and lower limb during examination, there is difficulty in walking, numbness in fingers and hands, small muscle of wasting of hand, and the mass effect. The mass effect itself in the, that is malignancy in the chest, it may cause dysphagia, dysphonia, hoarseness of voice, superior vena cava obstruction, that is swelling of the upper chest, swelling of the face, and swelling of the neck veins. Other association with CA lung is dermatomyositis, polymyositis. Polymyositis is more common. So the differential in this case includes CA lung, pulmonary TB, bronchiectasis, obstructive airway disease, uh, aspergilloma, that is ABPA, and lung CA is the second most common cancer in both male and females, irrespective of gender. The type of CA lung, the small cell CA, a limited disease and extensive disease, while non-small cell carcinoma, so the age is more than 40 years. Small cell carcinoma occurs in 10%, while non-small cell carcinoma occurs in 80% cases. The non-small cell carcinoma includes squamous cell carcinoma, adenocarcinoma, large cell carcinoma, and bronchoalveolar carcinoma. How to investigate a case suspected of CA lung? First, the baseline investigation CBC showing anemia, leukopenia, thrombocytopenia, to see whether bone marrow is involved or not. Bone marrow metastasis commonly occurs in CA lung. High ESR, if LFTs are deranged, it shows organ involvement. So we have to check the baseline liver function test and renal function test. Chest X-ray may show how homogeneous opacity, pleural effusion, hilar lymph node enlargement, rib erosions, and collapsed lung. Sputum for culture and sensitivity for to rule out any malignant cells and to rule out other diseases like pulmonary tuberculosis. CT chest with IV contrast is more specific and sensitive. That is more than 70% specific and more than 70% sensitive. After that, bronchoscopy comes. Excision biopsies from the lymph nodes are taken. Transbronchial bronchoscopy, transthoracic. So there are 7 routes of bronchoscopy: transbronchial, bronchoscopy, transthoracic, mediastinoscopy, CT guarded, MRI guarded, fiber optic biopsy, fluorescein bronchoscopy, and transesophageal bronchial biopsy, endoscopic biopsy, electromagnetic biopsy. electromagnetic navigation biopsy. So lymph node biopsy is excisional, CT guarded is simple lung biopsy, transbronchial biopsy, fiber optic bronchoscopic biopsy, fluorescein bronchoscopy, transesophageal endoscopic biopsy, and electromagnetic navigation biopsy. If these fail and does not yield a result, then we go for open lung biopsy or thoracotomy or VATS, the VATS. Why auscultation of heart is important in CA lung? There are two possibilities. Number one is infective endocarditis, and number two is pericardial effusion. Ultrasound abdomen is also required to rule out METs in the abdomen, or can be followed by CT scan abdomen and pelvis with contrast, or PET scan to rule out metastatic lung disease in the abdomen. Pulmonary functions test before surgery. So if it is uh, limited, like FEV1 is less than 1.5, we can't do pneumonectomy or lobectomy. So pulmonary function test has a role in lung surgeries. Now, screening of lung cancer, when and how. Every smoker should be screened, and how, that is low dose helical CT after the age of 50 or after giving history of more than 20 pack years. Central lesions are usually small cell carcinoma. Squamous cell are central and small cell are center. Peripheral lesions include large cell adenocarcinoma, bronchoalveolar carcinoma. The peripheral lesions, their biopsy should be taken by CT guided or VATS, or open lung biopsy or electronavigation biopsy. The electromagnetic navigation biopsy is the latest procedure in which both central and peripheral biopsies can be taken. Treatment of CA lung includes, first of all, the TNM staging, and it only applies on non-small cell carcinoma. The small cell carcinoma includes, its treatment includes chemotherapy, that is, there is no TNM staging for small cell. So chemotherapy includes cisplatin, etoposide, or carboplatin epopostate, or carboplatin plus etopsin, or there are certain drugs like zurvalimumab plus minus radiation therapy plus minus prophylactic brain radiation in small cell carcinoma. If it is limited small cell carcinoma, unilateral hemithorax involvement, that is called limited small cell carcinoma, unilateral and hemithorax involvement. While if it is extensive, both hemithoraces are involved with pleural effusion. And if brain mets are involved, thoracic radiation plus prophylactic brain radiation and resection is done. For extensive small cell carcinoma, alizolizumab, cisplatin plus etoposide. And for pleural effusion, thoracocentesis, pleural catheter placement, pleurodesis, and pain management is done. For brain metastatic lesion in small cell carcinoma, radiotherapy and resection is done. Now, what is the survival or prognosis? In limited small cell carcinoma, if treatment is given and it responds, 20 months is the survival. While if there is extensive small cell carcinoma, 8 months to 1 year is the survival rate. Now we will discuss the treatment of non-small cell carcinoma. It includes, first of all, the TNM staging. T0 means no evidence of primary tumor. T1 is carcinoma in situ, TIS. T1 is less than 3 centimeter. T2 is more than 3 centimeter but less than 5